Thank you. So, as Mari mentioned, we have two objectives in this very big project, and it's kind of very interesting in a way that WHO usually engages in research, evidence-based research that they do for many, many years. They gather evidence and they produce guidelines. So this project is for the first time, they do evidence-based research, but we have a service design component in that, and that's the first time that WHO looks into using innovation and service design as a part of this process in creating maybe even guidelines and new ways of solving health issues. So we have these two objectives, SELMA and PSP. SELMA means Simplified Effective Labor Monitoring to Action Tool. And that's already what Mari mentioned, will be a rethink of how women are monitored during labor. There's at the moment, I think, 20 different indicators that a midwife needs to monitor, from the fetal heart rate to her temperature, the urine results, the contractions, the dilation, the descent of the head of the baby, and so forth. And this is a very tedious task, and it's very complicated, and labor is dynamic. Labor is not static in a way that it develops from one step to the next, but it changes every 5 minutes, maybe sometimes it changes every 4 hours. And it's really hard for midwives, especially in very crowded settings, to keep up monitoring this, especially if modern technology, monitoring technology is lacking. And just as a comparison here, usually there is one midwife for most of 2 women giving birth. And in these settings, there might be one midwife with 8 women that are at the same time in labor. So we have seen and heard that there's a woman delivering, she takes out the baby, gives it to the mother, goes to the next one. And it's like, it's very shocking. It's like a conveyor belt situation in some. And how can these midwives then manage complications? How can they see when something is wrong, when something needs to be done? So in this initiative, we are looking at can there be anything, we are going to observe about 7,500 women in a study and record their monitoring data. That's done by WHO, and to develop new labor curves through artificial intelligence and dynamic modeling. And based on this kind of modeling, we will develop a user experience and a new tool that then midwives should help to make better decisions and understand that, okay, based on the data that we have collected now, this woman might have obstructed labor, this woman might need to get a C-section. Then on the other hand, which is like kind of what we're mostly focused on right now, is the passport to safer birth. And that is an initiative to identify a new set of solutions and services that could help inform women and their families about pregnancy and childbirth, prepare them, help them understand what is to be expected, move them into the facility, and in the facility enable them to demand better quality of care, and also the midwives to provide better quality of care. Here's just an example of the Paragraph tool, and you can see it's kind of very difficult. So it's a 50-year tool, and if we look at the passport to safer birth, in service design, we know the term customer experience, but customer experience requires that I have certain expectations towards a service, and the service provider knows these expectations and can maybe fulfill those expectations. But the problem we are facing in many low-resource settings is that people do not have any expectations. They don't know what to expect. They don't know what is even happening in their body. So how can they demand the right quality of care that is given to them? And the same accounts for midwives providing the quality of care. So what happens is that in many situations there's a lack of personal attention to women in these settings. It has been reported there's a lot of disrespect and abuse, like beating, shouting, yelling, ignorance towards women giving birth. And this is probably, you can imagine, the last thing that you want to experience when you're having a child. So we are trying to understand what can we do about this through service design? And we know that in service design, we like to think about touch points and journey. So our study scope for this initiative, can we actually take off the light?
Yeah.
I think it's better to see. We want to travel with the woman from the community to the facility and back to understand that what are the different pit holes, what are the bottlenecks in her journey, from preventing her, firstly, maybe to go to the facility, from knowing enough about pregnancy and childbirth, from identifying the risks that she might carry, and so helping her to seek earlier care, and then in the facility support her, and then also when she returns back into the community. Just as an example, many women, they don't know anything about, when labor starts. We heard just last week that one woman thought she was having malaria, and then she was giving birth. So it's really hard for us to understand that how can that happen, but it happens every day. During referral and transportation, there is no transportation available in many places. How does the woman get to the facility? Often she will ride on a motorcycle in labor to a facility. Sometimes there is an ambulance available, but you need to pay the fuel in order to be transported to the hospital. So again, here there's a lot of bottlenecks and barriers in this area. Then in the facility, I talked already about disrespect and abuse. There's some hospitals there are congested. National referral hospitals are full of women. They have approximately 800 births a month. Compared to here, we have, I think, like a fraction of that kind of the birth amount. And then again, returning to community, like what does it mean coming home with the baby? How can you check up on your health afterwards? There's a lot of risks associated. Again, you come back and should go to a checkup. Women don't understand why they should go and check their baby, immunize their babies, or have a postnatal checkup themselves. And how do we do this? We have two big parts within this process. One, it's the standard service design process, but we have the discover and define phase when we go and observe people, their relationships and their actions. We talk with women, hospital staff, and all other stakeholders, and then we identify the ideas and solutions, what can be done. And then in the second phase, once we have done this, we will do co-design together with women in these communities and also with hospital staff. Build tools together, then we'll try them out in practice. We'll try them out in the facilities and in the communities, and then we will refine them and finally create them finalized prototypes that then WHO will test in a 5-year effectiveness studies whether these tools will have an impact and actually can be employed on a global level. Where are we going? So we have started with a big desk study where we reviewed all the different academic papers and research, because the maternal death and maternal mortality and related issues have been researched for many, many years already. So we've been creating a picture of what are the things that we know and what are the things that we don't know, and where can service design research go and identify opportunities. So we had an initial visit to Uganda, which is one of our locations. Nigeria is the other one where we will be working. And we went to see different facilities and set up our structure, met with local partners. And now for the past month, we've been preparing the research, the service design research. We were actually hoping that we would have completed by the end of this year a much bigger part of our project already. But as we need ethical approval for such a process, when we are talking to women, we go into the facilities and observe deliveries. There needs to be an ethical approval from WHO and also from the country ministries of health. So this process has taken almost 6 months. We had to outline all of our methodologies, our approach. And since it was very new, there was a lot of work we had to do towards this. But finally, the approval was given, and last week we have gone on our first design research trip to Uganda, and the team is still there and saying hi to all of you. I came back on Saturday. So we'll have a 2-week service design research in different communities over there to gather insights. We'll do in-depth interviews, direct observation, shadowing, and then have some group discussions. Come back, we will analyze what we have, and then in January we will go to Nigeria to do the same. That will give us a picture of how different are these two locations, what is similar, what is different in terms of problems and issues that can be solved. And then we will synthesize, and at that time the research data from WHO team comes in, who's also doing focus groups and in-depth interviews on a bit bigger scale. So we will synthesize our results with the academic research and see what kind of outcomes come out from service design research and what kind of outcomes do we have from academic research and how they can complement each other. And this will be a very interesting thing because no one has done this yet, that we do either academic research or service design research, but now we have the chance to actually tackle the same topic with both of them and see how they actually complement each other. So after that, we will spend some time ideating and preparing, and we will go back to Uganda in March to do co-design together with women and staff in the facilities. Come back and analyze that and do the same in Nigeria, after which we will then refine and design our tools. And then we will go back and test them. And then finally, by October, should have our solutions and the research strategy compiled. What are we looking at when we go to these locations is we want to look at the extremes. Because no facility is like the other, and it's really hard to kind of say, okay, if we go to a low volume facility in the countryside or if we go to an urban facility, they have very different challenges. So we kind of chose what is lying at both extremes. So last week we were in, this is a little bit exaggerated, it looks very modern, but it's actually not. We were in a very urban community of Kampala, the capital city of Uganda, and spent time in 2 different facilities. And Kampala has one of the most crowded hospitals, I think, even in the world, and it's completely congested. Women are giving birth on the floor, they're camping with their mattresses on the corridors. And it's a organized chaos or a chaotic organization, how one wants to see it. So they have the challenges that too many women come here, so that quality of care cannot be provided in a way that it should be. And we're trying to identify what can help them to kind of maybe decongest or streamline their activities. At the same time, we go to the some urban communities, and urban communities sounds quite developed, but it's actually not. There's a lot of people living in these urban communities who have no access to electricity, running water. They live in a room that's as big as 1 mattress with a family of 5 people. They have nothing to do, like the man is working during the day and the woman might sit with the kids at home in this dark shack and has no money to do anything. So life happens to her. That's kind of the way she's living. And so how can we support these people to understand and empower them to be more knowledgeable about their pregnancy and childbirth? Then when we go to the community, to the rural area where our team is this week in northeast of Uganda, we have very different challenges. A rural facility which might have a lack of electricity at times. They have all the equipment there, but if there's no electricity, they cannot use it. Also, the midwives that are here, they're less skilled. They have not that much experience because we have less people giving birth here, so we have also less complications. And if there's complications, usually they are referred to urban hospitals. So for them, it's really a challenge to identify when complications occur and what to do and how to deliver good quality of care in that respect. Again, in the community, then in the rural community, we have the challenge that there's a lot of myths beliefs and superstitions among the communities that prevent women from seeking care when they have problems. When the women experience pain, they are being told by traditional birth attendants and other community members that, you know, it's just okay, it's good to wait, and they bring her to a church or to a place where she has to wait and she might die there. There's a lot of herbs, local herbs that are being used that tell you if you drink this herb or if you massage it around your body, you will have a good delivery, which of course we know is not always the case. So how can we tackle all of these superstitious and myths and wrong beliefs is a big challenge. What we're talking to is we want to kind of take the whole spectrum of influences that have an influence on the woman's perceptions and experiences. So that have traditional birth attendants and community health volunteers. We talk to mothers, to doctors, to the women themselves, to nurses and midwives. But really importantly, that has been pointed out in the past weeks, it's men. Fathers and fathers-to-be, as in these cultures, men have the most of the decision-making power. So we're trying to tackle and understand, like, what is it, how is the relationship between men and women, and what can be done here. And then, of course, mothers-in-law and the extended family is an important stakeholder too in the decision-making process. So what are we looking at is, what are we researching is the perceptions and experience during pregnancy and childbirth. How do women there think about, you know, their body, about pregnancy, but what have they experienced during childbirth? We are looking at the interactions that actually happen between staff and the clients in the facilities. We are trying to understand what is the knowledge and information seeking behavior of women. Where do they get their knowledge from? They don't have access to internet, they don't have access to books. There's a lot of word of mouth, and which has a huge impact on decision making. Then, of course, we look at clinical practices and routines, and this is exactly, you know, where customer experience comes in, is that there's no real concept of customer experience. People do their job. And how is that done? We are trying to look at, we have this myth and religious beliefs, as I said already, but we have also a lot of other barriers and obstacles, one of which I mentioned already, transportation, but then we have stigmas like HIV, which is a huge problem also over there, that women are afraid. If they go to a facility to deliver, they are being tested on HIV, the husband might know, and it might create huge problems within the family. So, there is still a lot of awareness and communication need around HIV and other diseases there. And then, of course, we want to look at the decision-making process on how a woman makes a decision, where to go, where to give birth, and then what to demand. But it's an issue too, yes. So as I said, we have done this big desk study. We reviewed papers. We had a lot of interviews. We looked at a lot of different projects and innovations that are out there. And it's very important to get like a very deep insight before we start into what are we tackling. So based on our desk research, we recreated the woman's journey. That is our study template for our design research. So we have the pre-pregnancy, we have pregnancy, delivery, and postpartum. And during our design research, we are now trying to identify what are the key touch points that the woman goes through that will shape her experience. We will also identify the specific journey moments, how the stakeholders are involved in each of these phases, what are the woman's experience and feelings. Here we have mapped based on the desk research, what are the key topics that we should look at. For example, attending antenatal care. Here in Finland, for example, a pregnant woman goes to antenatal care every month almost. In the last weeks before her birth, she almost goes weekly. And the worldwide recommendation is to have at least 4 visits of antenatal care. And nowadays in urban areas, many women attend antenatal care, but the women there, they don't understand why they should go to antenatal care. The only thing that they think about is that they will be tested on HIV. And actually antenatal care in Ugandan language has been translated into giving medicine. So many women go to antenatal care expecting medicine. So then they give them a pill of paracetamol or, some placebo, so that they get the feeling that when they come to antenatal care, they get something. So there's already issues involved in language that kind of create certain perceptions of what antenatal care is about. So finally, we'll map the bottlenecks that we identified and also ideas and solutions for this. So last week we've been in the field, and this is a little team says hi. Here's our team with our local partner in Bududa in east of Uganda. We have, because we mentioned the literacy problem, we have designed a set of tools that help us in our design research. We've used a lot of illustrations to help women point at certain topics, and we have, of course, pointed out a lot of these taboo topics like HIV, malaria, for example, money, to kind of help women express how they feel about certain issues. Then we'll have, we're doing group discussions. So here you can see the women talking. This is using the tools with a couple. So here we were talking to a married Muslim couple. The woman is hiding. She was really shy behind the bed. And he actually said that he prevented, they weren't married yet when she got pregnant, and it was clear that it was an unwanted pregnancy. And so they first had to introduce themselves to their families to say that we are getting married. So that was the reason why the visit to antenatal care was delayed. And then, that might be too late in order to identify any complications in your pregnancy. And he didn't really quite understand why, for him it was crystal clear that first I need to present and propose my wife to my family, and I need to collect money for that. And that might take up all the money this family has over several months. And then the introduction to the family happens, and only after that she was allowed to go to antenatal care. And then we've been following several pregnant women throughout their whole day. So we spend time at their home, see what kind of work they do, how they think, and you get into different in-depth discussions when doing just an interview, because the interviewer can gets to know to the woman, and the woman finds trust. So get very different insights from this kind of type of observations. And then also interviewing and having private discussions with women and their families. So right now we have already analyzed the kind of decision-making process and by what is it influenced. So this is when we've been mapping that, we have wrong beliefs, we have ignorance, we have misinformation, we have wrong motivations, we have reputations, access, money, I can't read this, and quality of care. And then we've been mapping all the kind of stories that we heard to these different categories to see, for example, elderly people say that men should not see the delivery. And then some people even said that no one of the families should see the delivery because it makes the woman weak. So there's lots of these kind of myths and wrong beliefs that have a big impact on this process of delivering quality of care. As I mentioned already before, as an example, there might be an ambulance, but it's without fuel. And if you have a complication in this hospital, you need to be referred because they cannot do C-section. So if you don't have $5 to pay for the fuel, you might not be referred. One case in Nigeria happened while the WH team was there. The woman had to be referred and they didn't have the money to pay the ambulance, so they took a motorcycle. The cousin, so it was a driver, the cousin, and the woman went on the motorcycle, came into a traffic accident. The woman and the baby died, the cousin died, and the driver was very badly injured. And you think that's $5 that was lacking. It's quite shocking. And then we have another challenge that it's a, when you come here to the hospital, you have nice sheets, everything is provided for you. You just go to the hospital and give birth. But women here, they have to bring everything themselves. They have to buy this mother's kit, which has like a sheet, a plastic sheet that is spread under you when you're giving birth. And it's very cold and terrible to be on a plastic sheet to give birth on. There's soap, then there's the surgical gloves that the nurse will use. There is cotton wool to kind of use it after birth against the bleeding. There's cord ties and the surgical blade to cut the umbilical cord. So even that, the woman needs to provide herself. And this is, again, a very big barrier for women to actually go to the hospital to give birth, because some people just don't have the money to buy that. Luckily, there are some governmental programs that make this package now accessible to some women for a lower price, but it's far from what we know as the maternity kit in Finland, which provides clothes and all these nice things. And then here a picture of these kind of herbs that are being prepared to tell women that if you drink these herbs, you will have a good delivery. And this again results into many problems, because women think that if I drink this, my delivery will be fine, but if I then experience a complication, there's no explanation for it. Then it's my fault. I have done something wrong. So people are not used to think about problems in a way that there can be a logical explanation. Usually it goes into some myths and strange stories. Yeah, another woman with 3 children who didn't have a husband ran away, and she was now sitting there with her 3 kids and living off the kind of grace of her 90-year-old grandmother. And the attitudes that they have is that, okay, life is happening. I can just wait and see. There is no way that I can influence my own destiny. And I think that's the kind of biggest challenge that we're facing when we think about service design. We always assume that our customers, they have needs, they have expectations, and our customers we're working here with, they're quite demanding. So it's actually, if you think about it, quite easy to have demanding customers. But if we have customers that cannot even demand, kind of, how can you help them actually, first of all, to realize their demand? And this is another image from Mulago Hospital, where all the family members are waiting outside the delivery. They bring the food and the washing bins while the woman is in the hospital. They need to wash the laundry and take care that food is being provided. They bring the mattresses in case there is no bed free to sleep. Sometimes after birth, 6 women share one bed. And you have your baby here, and then you share one bed. And then we, of course, looked, and you asked about mobile phones, we looked at different use of technology in different areas where we work with. This is a community health volunteer who's actually using a mobile phone, and we were asking her how she's using it. And then we get a lot of good kind of ideas from her. She says, she was using this mobile phone, and then she says, like, this makes me focus on one thing because it's so small. I can do only one thing at a time. And then she had this big paper list that she was filling out. And I was thinking, why are you still filling this out when you have it all in your mobile phone? And she said, this makes my mind think big. So this gives very valuable insights on, we cannot only think technology as a solution. Sometimes the paper is just more beneficial. Then we also do some quick prototyping and testing already while we're doing design research in the facilities. So here we just sketched a little tablet and tried to map some features to help midwives to understand, to manage that chaos. As an example, how many women have you admitted? How many are in the first stage of labor? How many women need to go to have a C-section? And how many are approaching second stage? So that means delivery. Because right now, in many hospitals, midwives do not have the overview of in which stage these women are. what are we going to do with all of this input that we're gathering in this design research? Here's an example, is that now we have already created midwife profiles, and we will do also profiling for women and community members. And the difference in profiles from user personas is that they are kind of just profiles. They are not personas which go very much into detail. It helps us to kind of stay on a little bit more general level when we think about, what kind of tools and solutions could be applicable. So, for example, here we have identified 4 different midwives. We have, on one axis, we have experience and intuition versus lack of support and uncertainty. And on this axis, we have midwives who work in teams and where complications are taken care in the facility versus midwives who are often working alone and complications lead to referrals. So we have, for example, the rescuer here, which she's a very experienced midwife, but she works in a big team and the doctor is not always available, so she can actually make the right decisions, but she needs to have a doctor to approve that decision to send a woman to cesarean section. So she's sometimes in chains because she could take care of a lot of patients, but she cannot make these decisions. Then we have this less skilled midwife who is in between, she's following different people and she needs to ask for help and advice. So she needs kind of different support during her work. So based on these kind of profiles, we're mapping like what are the key opportunities for each of these profiles with regards to services and tools. For example, for the rescuer, the key, what we see here, is validation. So I make a decision, can the doctor please validate it? And really often, a doctor might ignore her because the doctors are much higher than midwives. So even though the midwife says this needs to be done, and she might be right, the doctor might say otherwise. So how can validation help her? And then helping her in documentation of labor monitoring. Versus the follower would need much more support in time and task management. So then we also kind of ideate what kind of touch points would be valuable. And here for this exercise, we did it now on a digital level, but obviously our solutions will not be only digital. But here, for example, we just looked at in the delivery room, we cannot really have a big tool. We cannot have anything because the midwife should be with the patient. So is there anything small that, could just beep or alert and help her in different situations? And then finally, we are creating scenarios that then kind of illustrate the service opportunities. Here we have an example of the labor monitoring. So could you have an overview of all those women and when they have been admitted, in which stage they are at, and when they need checking up next time? So this is just an example that we're exploring. Again, this is like focused on digital technology. We're looking more broadly also how we can improve on a service process. Finally, we tested some of these kind of different tools already with some of the midwives. And our next step is, of course, starting to co-design after our design research together with women and see what could help them. But this was one comment. Service design sounds like a wonderful approach. Rarely have I been asked what would really help me. Contributing to designing the solutions I will use makes me feel empowered and valued. And I think this is really the power of service design, because we see that a lot of these solutions lie among these people because they work there every day. But because they don't have a problem-solving attitude, they cannot formulate, they cannot bring these thoughts out, and they don't know what to do with this thought. They might say that, this is a chaos, but they cannot find a way how to get out of the chaos. So I think in taking this design research and co-design approach, we will be able to kind of identify these ideas that these people have on what could be improved and then turn them into actual solutions. So as a final kind of summary, I think service design as an approach and then design thinking as an attitude can help us in designing healthy systems in a healthy way, because we can, of course, design healthy systems, but we can like design in a healthy way, that is service design, but we also need to design healthy systems. That means systems that can last and be sustainable, and that can be also implemented. Thank you.